Sorry for that. Marami pa kasing pumapasok. So anyway, so let us start. So first, we have the term anterior or ventral. So simply it refers to the front or the forward part of the body. So the forward or the front part of the body or towards because it is a directional term towards the anterior part or the front part of the body. And also we have the term posterior or dorsal. So it is the opposite of anterior or ventral. So it is the backward part or the back part of the body. Another term is medial or mesial. So they mean the same. So towards the median plane or the middle part of the body. For example, the spine is medial to the kidney. So meaning the spine is at the center or it is nearer the center or towards the center of the body as compared to the kidney. So also the term lateral, it refers to the position away to the median. So lateral is the opposite of medial. So if medial is towards the mid part of the body, lateral is away to the median plane. So this time we can say that the kidney is lateral to the spine. So meaning kidneys are more away to the midline of the body as compared to the spine. Another term is proximal. Proximal is near or close to the point of origin or attachment. So for example, we have here elbow is proximal to the wrist, meaning mas malapit yung elbow sa point of attachment or point of origin. For example, we have the shoulder, yung point of origin, so mas proximal ang elbow than the wrist. Or we can also say, else, lang, papasok. So we can also say that the knee is proximal to the foot. So, mas malapit siya sa point of origin or attachment. The opposite of proximal is distal. So, meaning furthest to the point of origin. So, fingers are distal to the wrist. So, parang nasa dulo siya. So, cephalad, meaning towards the head or towards the cranium or the skull or towards the cephalic part or superior part. The opposite is caudal. So towards the inferior portion or this is away to the head. Ito towards the head. So we have again ventral and dorsal. They are opposite each other, or anterior or posterior. They are opposite. Medial and lateral, they are also opposite. So medial towards the midline, lateral is away from the midline. Proximal, close to the point of origin. Opposite of that is distal, furthest to the point of origin. Next, cephalad and caudal or caudal, they are opposite each other. Cephalad towards the head, caudal towards the tail or feet. So we have here an illustration. So distal is away from the point of origin. So papunta sa dulo. Then midline. So papunta sa midline, medial or mesial. Away from the midline is like indicated by the arrow, that is the term lateral. So distal papunta sa dulo, proximal towards the point of origin. So distal going away to the point of origin, then we have the proximal towards the point of origin. Superior, we can also say that it can be referred to as superior or cephalad, inferior or caudad. So before we proceed, so I have here a video to add knowledge to what we have discussed on the directional terms.
So, your head is on top of your body, right? I mean, of course it is. It sits on top of your neck, and that's above everything else. What about now? I'm Patrick Kelly, and today we're learning how to describe where things are on the body. We call these directional terms. And if you watched my last video about naming the regions of the body, you know what they're called, but now we have to talk about where they are and how to get to them. And to give accurate directions, anatomists need a consistent map to base them off of. That's why we use the anatomic position, a standardized position that we picture in our heads whenever we're using these directional terms. Here, stand up and do this with me. It's standing up straight, feet flat on the floor, looking forward, arms by your side, and palms facing forward. This will be forever and always your reference point for talking directional terms. Now, this body thing is three-dimensional, so we're going to need some axes and planes to work with. And you can think of these like lines that slice people in half. Like imaginary. They're imaginary lines. First up is the transverse plane, which cuts people into a top half and a bottom half at the waist. And let me just blow your mind with some magic. It cuts people into a half that looks like a T and one that looks like an upside down V for transverse. The frontal plane just divides the body into a front half and a back half. Not nearly as mind-blowing, but it is easier to remember. Finally, the sagittal plane divides the body into a left half and a right half. It's the only way that you can divide a body into two identical halves. So I remember this one by the two identical T's in the name. And because the sagittal plane gives us two equal sides, it also gives us our midline, which helps us establish our first two directional terms. There's medial, which means we're going towards the midline, and lateral, which means we're going away from the midline, or out to the side. If you've seen a lateral in football, it's really similar. It's when the ball gets passed sideways. It's the same thing in directional terminology. And since you have two equal sides of the body, things can be bilateral, which means that they're on both sides. Now, maybe you're thinking you're all high and mighty because you learned some directional terms. You might even think that you're superior to all others around you who are inferior. First off, wow, that's incredibly rude. How dare you talk about people like that? But also, those are our next two directional terms. How did you know? Superior means pointing towards your head, while inferior means pointing away from your head. Now, if I look down or inferiorly, do you see that? Ah, it's ants, which is exactly how you're going to remember the term anterior, referring to the front of the body. And on the flip side is the posterior, or the back half of the body. And excuse me, would you please stop staring? Gosh, you're so superficial. Luckily, superficial is the directional term for shallow, or towards the skin. And on the other side, you could be going deep, away from the skin. Now, the limbs get their own terms because they're all over the place. If you take your arm out and look at your fingers, they're so far away, they're so distant, which is exactly how you're going to remember that directional term. Anything away from that joint is going to be distal. But if you look at your shoulder, it's in way closer proximity, which is how you're going to remember that directional term, proximal. And you can say the same thing for your leg. Your hip is proximal to your knee, but your toes are distal to your shin. Speaking of your toes, that whole foot thing doesn't really have an easy shape. So we call the bottom of your foot the plantar side, and the top part of your foot the dorsal side, which is the side that you tie your shoelaces on. And you'll probably tie those shoelaces with your hand, which have a palmar side and a dorsal side as well. Now that you know the basics, you get to have some fun with them. You can start using them to give directions all around the body, like, I can never reach my posterior thoracic. Can you scratch that for me? Or you can use a combination of directional terms. Yeah, that's good. Just like a little more superior laterally. And really, you never know exactly when you're going to use them, but you do know for sure that you are going to use these every day in your study of anatomy. And if you need a refresher on the regions of the body now that you are Directional Terms Pro, you can go ahead and check out this video right here. And if this video helps you out, move those phalanges superior.
Okay, so let us continue. So I hope you have understand better the directional terms. So we also have the relationship terms. So again, just like what I have discussed, the medial versus lateral. So again, medial towards the midline and lateral is away from the midline. Proximal versus distal. So proximal is near or close to the point of origin, and distal is away or distant from the point of origin. For cephalad, so towards the head, and then we have caudad towards the feet. Interior towards the inside, and exterior is outside. Superficial is a shallow portion versus the deep portion. Ipsilateral meaning they are on the same side. So the same side. While contralateral, contra is against, meaning they are on the opposite side. So again, ipsilateral, so C, same. Contralateral, contra, contrast, that is opposite side. Okay? Yes, so let's continue. So we also have here body movements. So flexion versus extension. So flexion, you're going to flex. So degrees of the angle of the joints by bending. So later I have pictures there. So anyway, this is just a review. So extension is to increase. So this is, sorry, decrease. Decrease the angle, not decrease. Wait lang. So allow me to erase this one. So this is not degrees, instead this is decrease. Decrease the angle. So we have here, for example, flexion of your arm, for example. Extension is increase. So this is flexion, this is extension. Okay? So they are opposite each other. So opposite of flexion, extension. Extension, decrease. Flexion, so flexion is decrease, and then extension is increase. Another one is inversion and eversion. Inversion is turning the foot inward. Eversion is outward. While dorsiflexion, so flexion between the lower leg and the foot, so the angle between the structures is less than or equal to 90 degrees. So we can also make a dorsiflexion of our foot and leg, and also we can do that uh, with our hands, but it is referred to as palmar flexion. Another term is abduction in adduction. So, abduct, so parang kinidnap siya. So away from the family. Kapag kinidnap ka, so abduction, away from the midline. Adduction is towards the midline. Pronation, from the root word prone. So turning onto one's stomach or turning the hand so the palm is down. So going to prone position. So you are lying on your stomach, or if you're talking of the hand, so the palm is downwards. The opposite of that is supination. So you are lying on your back, or your hand is positioned where your palm is facing forward. Rotation. So rotate, circular movement. Tilt, So the body part, moving the body part, so the sagittal plane is not parallel to the long axis of the body. So for example, ito siya. So we tilt like ito. So this is not parallel to the long axis of the rest of the body or the body part. So ito siya. So also rotation or circumduction. So in a rotating manner, abduction is away. Then we have siya, abduction away from the body. Adduction is towards the body. Pronation, the palm is downwards. Supination, palm is upward. Flex, you decrease the angle. Extension, you increase the angle. So, pwede ring adduction towards the body. Ito yung mga fingers, they are adducted. They are close to each other. Abduction, they are away from one another. So we also have here lateral rotation versus medial rotation. So you rotate in our example here. So we rotate the feet or foot. Pag lateral, away from the body. Pag medial, towards the body or towards the midline. So I also have here another video for that.
Well, anatomical yoga. We'll start at the top of our mat in the anatomic position. Gently elevate and retract your scapula with ever so slight cervical circumduction. Now, flex your dominant hip and knee while an externally rotated contralateral hip and flex knee allow you to rest your foot on your thigh. Next, we'll move on to my favorite, the downward descendants.
If none of that made sense, then keep watching this video because today we're talking about movement terms.
What's up, y'all? My name is Pat Kelly. I got another anatomy lesson for you. Today, we're talking movement terms. These are all the motions as they apply to the body. So we're going to go over what those movements are, what joints they apply to, and give you a few memory devices so hopefully you can remember them easily. I made this video to accompany my anatomical regions and directional term videos. So if you haven't seen those, I recommend clicking that link right there to get a little bit of background. So here's the big picture. We have multiple joints that all move in incredibly unique ways. So simple terms like up, down, and sideways don't apply here. We need unique terms to describe unique motions. And when we're talking about anatomical motion, we reference an imaginary body in something called the anatomic position. That's standing upright with feet forward, arms by your side with palms forward, and head neutral looking forward. I've said it before and I'll say it again. Always refer to the anatomic position whenever you're talking about direction or motion. This is forever and always your starting point in anatomy. Why? Well, it's tempting to say something like move the patient's leg up to refer to hip flexion when someone is in the anatomic position. But that's a completely different motion than if they're lying on their side. So in order to standardize language, we always refer to the anatomic position. The second thing to keep in mind is that there are different planes of motion and different axes of motion with which these limbs and joints move around. Obviously, your body exists and moves in 3 dimensions. So while some motions seem like they happen in a very straightforward, linear way, most day-to-day motions are a combination of those. Let's start with abduction, which is movement of a joint away from the midline of the body, and adduction, movements towards the midline of the body, specifically this midline on the sagittal plane. Now, clearly these words sound very similar, and some folks will painstakingly spell it out abduction to make it super clear, but the difference is actually way easier to remember. I picture an alien abduction taking my arm away from me, whereas with adduction, I'm adding to the size of my body. You'll see these motions all the time with shoulders and hips, but you can also apply them to fingers and wrists. In those cases, abduction doesn't necessarily mean going away from the body's midline, but from the midline of the hand. So really, finger abduction is the same thing as spreading your fingers, while adduction is closing them. One little note though, Some clinicians will call this motion wrist abduction or adduction, but some will say radial deviation, meaning the hand is moving toward the radius, or ulnar deviation toward the ulna. They're the exact same thing, but since the hand and wrist are so often not in anatomic position, they're easier to remember this way. Next up is bending and straightening. More technically, flexion, which is a decrease in the angle between two joints, and extension, an increase in that angle. It's pretty intuitive for joints like the knee, elbow, or even spine, but some joints are a little trickier. Like this is shoulder flexion, and to me, it just looks like my arm is going away from my body. So I had to come up with a separate way to remember flexion versus extension. I remember that flexion is like the fetal position, which clearly both starts with F. Check it out. The hips and knees are in flexion, the shoulders, elbows, and wrists are in flexion, and the neck and all parts of the spine are in flexion. That's right, flexion and fetal, the two best F words for any memory device. Extension is the opposite. You're increasing the angle between two joints, which usually results in straightening the limb or extending it past that frontal plane midline. But be careful, because flexion and flexing are two very different things. When we say flex a muscle, what we're actually saying is to put tension on it, to contract it. And yeah, when you're flexing your bicep, you're also doing elbow flexion, but you can flex your quadriceps while you're extending your knee. Got it? Rad. Moving on. Next up is medial and lateral rotation, sometimes called internal and external rotation. And just like picturing rotation from physics, we first need to figure out what our axis is. So for both the shoulder and the hip joints, our axis is going to be an imaginary line running through the long bone of those joints. You can do this with me. If you stand up and lock out your elbow and rotate your shoulder so that your thumb starts pointing towards your midline, you've medially or internally rotated the shoulder. Now on the flip side, the thumb is heading back out, so we're doing lateral or external rotation. Same thing with the hip joint. If you stand up and lock out your knee, when the foot goes toward the midline, that's medial rotation. If it goes out, lateral rotation. But remember, movement terms use the anatomic position as a reference. So if we're in standing, we can get away with using our hands and feet as little guides, but that might completely disappear if we have our person change position. Like, imagine for whatever reason you wanted to assess a patient's internal shoulder rotation in a seated position. It's going to be really difficult to work with a straight arm, so you have your patient bend their elbow. Now, in this case, internal and external rotation still make intuitive sense. My arm is going towards the midline or away from the midline, which agrees with the long axis rotation we defined earlier. That's awesome. Unfortunately, that doesn't translate to the hip joint. Right here, I'm actually doing medial hip rotation. The long axis of the femur is rotating towards the midline, but my lower leg is all out to the side. Vice versa when I do lateral rotation or when you test this in the supine position. Okay, lesson learned, if you look at the long axis of the bone in anatomic position, you'll never trip up. So those are our major multi-joint movements, but there are some exceptions, and from here on out, it gets pretty specific. Like the radius has the ability to flip around the ulna due to a cool little pivot joint between the radius and ulna that's totally separate from shoulder rotation. This is called supination and pronation. Supination, everyone remembers because you flip your hand up like you're asking for soup. It gets dumber. On the other hand, I remember pronation because it's like a bunch of pro national football players all putting their hands in on the pile. Also, can I get credit for putting literally the other hand in? But it gets even weirder and more specific. Like the ankle joint, specifically between the talus and the lower leg, do something called dorsiflexion and plantar flexion. I remember these because when you point your toes down, you're planting your toes on the ground. Then when you point them back towards you, you're pointing them towards your dorsal aspect, your back, where we keep our dorsal fin. But the ankle can still wiggle a little more. That same talocrural joint rotates around the long axis of the metacarpals to do inversion and eversion. Easy way to remember those, if you invert your feet, your body will trip over and your body will end up inverted too. But you could forever comfortably stand in eversion. We're getting to the end. Lastly, we need to look at the scapula. They can elevate or depress, protract or retract, all of which are pretty intuitive to remember. Finally, we have circumduction, which is this big, silly-looking circular motion that happens at a few joints, including the neck, shoulders, and hips. Now, those are all the major motions, but there are a couple things to keep in mind. As a clinician, you're probably going to care about these movement terms because they're going to help you document things like range of motion and functional movements. Usually, we care about three types of movements. Active motion, which means the patient is moving the joint through their own efforts. Passive motion, which means motion is being done to them either by your hand or by a machine, and resisted motion, which is self-explanatory. some kind of resistance is being placed on that motion. And those are important distinctions to make because that might help you with your assessment. For instance, if somebody had painful active shoulder flexion, but they were fine on passive shoulder flexion, you can use that information. Now, all anatomy students are going to need to know these movement terms, but if you're more interested in movement itself, I'm going to recommend this playlist up here. It's my musculoskeletal biomechanics and
Okay, so let's end with that. So next we will discuss the body surfaces and landmarks. So these are very important, especially in our field, because we will discuss different central rays for different parts of the body, and these surface landmarks are very necessary for you to remember and understand. Okay, so for C1, wait lang. For C1, this is at the level of the mastoid tip. So later I have an image there. So C2 and C3, this is where we can find our gonion. Gonion is the other term for the angle of mandible. C3 and C4, this is where we can find our hyoid bone. This is the only bone in the body. Bone in the body that is not connected to any other bones. Yung hyoid bone, ito lang yung bone na hindi siya connected or attached sa other bones. C5, this is at the level of your thyroid cartilage. And C7, between C7 and T1, is your vertebra prominence. So in other reference books, they term this as vertebral prominence. Vertebral prominence. So this is the spelling of prominence. So prominence means this is something that occludes. So for example, we have here, so this part here refers to the prominence. For the thoracic area, T1 is at the level of approximately 2 inches or 5 centimeters above the level of the jugular notch. T2 and T3, this is the level of jugular notch. Above it, 2 inches above it, is your T1. So this, in T1, this is the uppermost part of the rib cage of when we inspect the lungs sa radiograph. So sa T1, this is where we can find the uppermost part of the ribs. T2 and T3, yun nga, level of jugular notch. T4 and T5, sternal angle. Then T7 is the inferior angle of scapulae. Scapulae or scapula. Scapulae pag singular. Plural pag scapula. T9 and T10, the level of the xiphoid process. The other term for a xiphoid process is the ensiform. ENSIFORM. For the lumbar area, so L2 to L3 is your inferior costal margin. L4 and L5, the level of the superiormost aspect of the iliac crest. Sacrum and pelvic area, so S1 and S2, so this is where we can find the ascis or the anterior superior iliac spine, and the coccyx is at the level of the pubic symphysis in the greater trochanterians. So as we go along, so for example, if we are exposing the patient for chest PA, chest X-ray PA, so you need to understand that the central ray must be at the level of, may late pa? level of T7. Sorry. Yes, correct. T7, which is the level of the inferior angles of scapulae. Okay? So, as we go along, you will learn and you will realize that these are very important external landmarks. So, ito siya. So, your C1 here, this portion here, this is where we can find the mastoid tip. So, also sa gonyon, C3. Then we have here sa C5, thyroid cartilage. So, between C3 or C4 or C5, we have your hyoid bone. Then C7 and T1, we have the vertebral prominence. Then T3, we have your jugular notch. So this portion here is the top of ear attachment. So there are also examinations involving the skull where we need to locate the T or the top of ear attachment. For C5, this is the level of the thyroid cartilage. Sorry. So sa mga lalaki, so the thyroid cartilage, para siyang dun sa Adam's apple banda. So ito yung T1. So sabi ko, ito yung pinaka-top portion ng rib. T2 and T3, jugular notch. T4 and T5, the sternal angle. Ito siya, sa sternum. This is the entire sternum. T7, so kapag nakatalikod ang patient, dito siya sa baba, lower portion or inferior angle of scapula. T9 and T10, so at the level of the xiphoid process or the xiphoid tip, yung pinaka-last portion ng ating sternum. So for your assignment, what are the three parts of sternum? So ito yung assignment niyo So this is due on Tuesday. Then L2 and L3 is at the level of the inferior costal margin. Ito yung pinaka-inferior portion ng ating ribs. So sa level siya ng L2 and L3 or the second and third lumbar spine. L4 and L5 is at the level of the iliac crest. Ito yung iliac crest. Ito siya, yung top portion ng hip natin. S1 or sometimes sa ibang book may S2. So this is at the level of the ASIS. Dito siya. Anterior superior iliac spine or ASIS. And then ang coccyx is at the level of the pubic symphysis and also the greater trochanters. So those are the surface landmarks that we need to understand, study, memorize, remember. Okay? So next we will discuss the different body habitus. So when we say body habitus, it refers to the body's physical appearance or the build of the patient or a person's body. So we have sthenic, asthenic, hypersthenic, and hyposthenic. So sthenic, these are athletic build, so average, moderately heavy, similar to hypersthenic pero modified by elongation of the abdomen and thorax. So later, I have a picture here para makita yung difference nila. 50% of the population are sthenic. This is the most common type of the body habitus. So for the organs of the sthenic, so the heart is moderately transverse. So parang nasa gitna siya. Lungs, moderate length. So, tama lang yung haba ng lungs. Diaphragm, moderately high. Ito yung diaphragm niya. Medyo mataas siya. Stomach, high sa upper left. Ito, mataas yung stomach. Then, colon, spread evenly, slight drop in transverse colon. Ito siya. Then there is a slight drop. Gallbladder centered on right side and upper abdomen. Ito yung green. Then, wait lang. So, ito siya pag sa another picture. So, ito yung stomach niya, higher on the left. Ito yung heart niya, nasa gitna. Lungs, mataas. Then, gallbladder niya dito. Then, evenly spread. Sa hypersthenic naman, so large and heavy. So, the bony framework is thick, short, and wide. Lungs and heart are high. Parang katulad din siya ng sthenic. So, mataas yung lungs and your heart. Then, transverse ang stomach, medyo papunta na sa gitna. Yung kanina sa sthenic, dito lang siya, banda, mas mataas dito. Then, peripheral colon, yung colon niya is more on the side. Gallbladder, high and lateral. Ito siya. Kanina yung gallbladder ng sthenic, parang nakadrop pa siya dito. This is only composed of 5% of population. The heart axis nearly transverse. So parang sa gitna na rin siya, tulad ng sthenic. Lungs, kanina mahaba yung lungs, lengthy yung lungs ng sthenic. Ito short lang. Apices, yung apex ng kanyang lungs, sa taas, are near the clavicles. Ito, malapit sa clavicle. As you can see kanina, dito, mas mataas siya sa clavicles. Saka medyo mahaba yung lungs. Dito, sa hypersthenic, short lang. Stomach is high, colon. So, sa periphery, gallbladder is high. So, the build is massive. So, ito yung mga matataba. Ito siya. So, short lang yung kanyang lungs. Then, medyo transverse na din ang kanyang heart. Gallbladder niya, mataas. Then, stomach niya, ito. Then, yung kanyang colon sa periphery or sa gilid. For asthenic, ito yung mga payat. So, slender and light. So, delicate bony framework, long, narrow thorax. So, mas mahaba yung kanyang thorax. Very long, low stomach. Yung stomach niya, tingnan nyo. So, hindi siya mahilig kumain. Kaya, wala siyang bilbil. Ito yung stomach niya, pababa. Para siyang fish hook, taga. Low medial redundant colon. So, yung kanyang colon, nandito siya. So, parang dito na lahat na buhos. Unlike yung kanina sa sthenic and hypersthenic dito, di ba, evenly distributed. Gallbladder niya, dito rin sa baba. Low in medial, papunta sa gitna na. Kanina, parang nasa right side pa yung gallbladder ng sthenic and hypersthenic. So, sa heart, nearly vertical. So, mahaba yung heart niya. Saka parang nasa midline. Long apices above clavicles. So, mas mahaba pa yung lungs niya kaysa sa sthenic. Then, above the clavicles then. Diaphragm, mababa, low. Colon, ito nga siya sa ilalim. Gallbladder, low then near midline. Build is frail. So, delicate. So, ito siya. So, yung kanyang colon nandito sa baba, yung mga payat, yung kanyang gallbladder parang dito rin sa gitna, yung stomach niya pahaba, and then yung kanyang lungs, so mahaba rin, saka above the clavicles. Yung heart niya, so andito rin. Then, last for hyposthenic, so mas payat kesa sa asthenic. So, somewhat slighter, less robust. Similar to asthenic, but stomach, intestines, and gallbladder are situated higher in the abdomen. So, yung kanyang stomach, intestines, and gallbladder, so mataas. Ito, compared dun sa asthenic kanina. 35% of population are hyposthenic. So, these are mixed between sthenic and asthenic. This is the most difficult body habitus to classify. Kasi parang pwede mong sabihin na asthenic siya or parang normal naman. So, it will depend sa nag-i-evaluate. So, ito siya. So, parang normal na parang hindi. Yun nga, difficult to evaluate. So, slender. Kasi yung asthenic, yun yung pinakapayat. So, to compare, so hypersthenic, so ito yung gallbladder niya. So, sthenic, ito sa baba. Hyposthenic, sa midline siya, then mababa rin. Asthenic, sa midline din, and then mas mababa. And then, for the lungs, so ito yung sa hypersthenic, so sa level ng clavicles. And then, sa sthenic, so sa taas ng clavicles, saka mas mahaba siya compared dito sa hypersthenic. And then, sa hyposthenic, mas mataas sa clavicles and mas mahaba siya compared dito. And eto, asthenic, mas mahaba. Ito yung pinakamahabang lungs and also above the clavicles. For the heart, ito siya parang maliit lang. Parang medyo pareho sila ng sthenic and hypersthenic pero mas malaki ng konti yung sa hypersthenic yung heart. And then sa hypo and sa asthenic, yung lungs ng asthenic yung heart ng asthenic mas mahaba, as you can see here. For diaphragm, mas mataas yung sa hypersthenic dahil pinupush ng stomach. And then sa sthenic, so parang okay lang. Medyo mababa na yung sa hyposthenic and ganun din sa asthenic. For the colons naman, so mas evenly separated siya, then usually nasa periphery or sa gilid. Ito, yung sthenic, so parang okay lang, evenly distributed, pero there is a slight drop dito. Ito, more on sa baba. And then sa asthenic, parang dito na lahat sa baba. Okay, so these are the comparisons. So ito rin. So you can see the difference between the hypersthenic, the sthenic, hyposthenic, and asthenic. So what is really the importance of this? So sa atin sa RadTech, these are very important, especially when we perform radiographic examinations of the lungs. So, halimbawa, pag yung patient mo is hypersthenic, so pwede kang gumamit ng halimbawa 10 by 12 or 11 by 14. So, kasya na yung lungs niya kasi maliit lang. Pero pag yung patient mo is asthenic, kailangan mong gumamit ng 14 by 17 na cassette kasi mahaba yung lungs niya. And also, when we examine the gallbladder, so dapat dito siya sa banda yung cassette mo. Whereas, if asthenic yung patient mo, so yung cassette mo dapat dito sa baba. So, dapat alam natin yung placement ng mga important parts or structures or anatomy ng patient dahil nag-iba yung position nila because of the different body habitus. So, same then, additional picture. Ito sa x-ray, so this is hypersthenic. As you can see. And then we have here, so letter A, that is sthenic. And then letter B, hyposthenic. So medyo payat na siya. Yung average is letter A. Then medyo payat, hyposthenic. Letter C, ito yung pinakapayat, asthenic. And yung mataba, hypersthenic sa letter D. So you can see the difference sa haba ng kanilang lungs. Okay? So ito yung sinasabi ko na it's very important for us to understand the body habitus para sa placement and tamang paggamit ng cassette size. Ito din. So, hyposthenic, medyo mahaba yung lungs. Then, we have the hypersthenic. So, short ang lungs. Then, we have the sthenic. So, ito yung average. And then, asthenic. So, as you can see, na-cut off siya. Kasi mahaba yung lungs niya. So, dapat babaan pa yung kanyang cassette. Dito banda yung cassette niya. So, the same then. Additional pictures. So, remember, sthenic and hyposthenic, they are more average body types. Parang normal siya. While hypersthenic and asthenic, extreme body types. Masyadong payat, masyadong mataba. When the patient is erect, the diaphragm lies in oblique position or plane in a level with the sixth costal cartilage anteriorly. Pag nakasupine, diaphragm is 2 to 4 inches higher. Pag naka-prone, diaphragm is 2 to 4 inches lower. So, ang diaphragm ng tao is tag-iiba rin yung posisyon depende kung ano yung kanyang posisyon. Kung nakatayo yung patient, yung kanyang diaphragm is more nasa oblique position. So, parang pagilid siya with the sixth level ng sixth costal cartilage sa harap. Pag nakasupine, nakahiga, then supine, diaphragm is 2 to 4 inches higher. Pag naka-prone naman yung patient, so 2 to 4 inches lower. So again, these are very important notes that should be remembered, especially when we place, again, sabi ko nga, ng cassette during examination.